Hi, nice to see you here. And then I will talk about some small and brief introduction about the new ablation technology, the irreversible electroporation. And I will talk about the current status in the Asia and about our performance. This is our disclaimer. And our targeted lesion and targeted disease is locally advanced pancreatic cancer. And as we know, more than 80% of pancreatic cancer has locally advanced or metastatic disease at the presentation. The early status and operable disease is quite rare. And the stage 3 locally advanced pancreatic cancer with involvement of the cetic trunk or the SMA has been nearly 50% of the new patient with advanced cancer, and the median survival for this kind of patient is just 6 to maybe 8 to 10 months, 4 to 3 to 6 months in metastatic disease. So the current standard therapy is limited, including chemotherapy, radiotherapy, or combination, and the local operation may be an emergent modality for these patients. And this kind of disease is very common when the pancreatic surgeon is doing their clinical, daily clinical activity. And the theory of electroporation is focal ablation therapy that uses a high voltage but low energy electric pulse to permanently open the pores in the cell membrane, which will cause the cell to die. These cells, when it is exposed to a specific electric field with higher electric field and longer pulse length, and the cell membrane will become reversible electroporation or irreversible electroporation. When we obtain this irreversible electroporation status, the cells will develop apoptosis, and this is what we want. And the current generator we use is a nanonite system. This system could deliver 3,000 voltage at current with 50 amperage. And the application of a rapid short pulse could induce the irreversible electroporation. Every pulse is contain 70 to 90 microseconds in length, and every session it will contain 90 pulses. This is here shown the electrode, and you can see the probe is quite fine. It's around the 19 gauge needle in the width, and with the echogenic surface. The tip is adjustable from 0.5 centimeter to 4 centimeter. You can use at the most 6 antennas at the same time.
We need a tester first.
When we perform the operation, you can see the electric power will make the muscle switch. And these electrode probes could be positioned under CT guidance or ultrasound guidance. And the electric field will be created between them. And this procedure should be performed under general anesthesia and complete muscle relaxation. At the same time, the cardiac synchronizer will be useful to prevent the cardiac problem such as arrhythmia and harmful muscle spasm. The benefit of IRE, unlike cryotherapy or RFA, it could prevent hissing effect and thermal injury because the treatment without exposure tissue to extremely high or extremely low temperature. And so-called hissing effect, incomplete ablation, or thermal side damage appear not to be applicable to the IRE. During the operation, no matter in Doppler ultrasound or the contrast-enhanced ultrasound, both of them show the blood vessel within the operation zone will keep a pattern. And you can see after the IRE treatment, the ablation size and the shape should keep a uniform no matter how close to the vessel or the vessel is just entrapped in the ablation zone. As for the ablation efficacy, there is a more precise therapeutic efficacy than traditional treatment, including radiofrequency ablation, RT, or resection. You can see even under the microscopic examination, the ablation zone is quite clear-cut in shape, unlike radiofrequency ablation, it contains the intermediate transitional zone. Because this novel ablative technology does not rely on heat to create a tissue destruction, so that allows us to treat a tumor near critical structure like blood vessel, pancreatic duct, bile duct, or visceral organ, and will shoot for patients who have no other choice, given the location of their disease. Especially, we focus on the locally advanced pancreatic cancer. You can see when we perform this treatment for the locally advanced pancreatic cancer, the adjacent vessel will be intact during operation, and after treatment, even the intrepid or encased vessel will be intact and won't be damaged. And the current indication of IRE for pancreatic cancer at my hospital was according to this guideline modified from the Professor Martin's opinion. We only perform IRE for locally advanced pancreatic cancer is so-called stage 3A. And the completion of the 3 to 4 months of induction chemotherapy, we saw without radiation therapy. In China and Taiwan, the radiotherapy for pancreatic cancer is not so common. And no significant disease progression means the disease was controlled and we can perform IRE for these patients. And the maximum axis and anterior to posterior tumor dimension was limited within 4 centimeters. The bigger tumor, we don't consider to perform IRE for them. And the patient should be tolerable to general anesthesia, intubation, and a complete muscle relaxation. And this patient is better without any history of a cardiac problem, including arrhythmia or uncontrollable hypertension, and no metallic implant, including the metallic stent. And there are 5 critical steps in precise IRE treatment, including the selection, the planning by a very precise and recent imaging, including CT or MRI. And then we have to design the IRE targeting the needle, how to press the needle, how to block in the tumor and to cover the entire tumor. And then we have to calculate the dose of current and the distance, and the measurement path and the resistance chain, and can we pull back to cover the whole tumor. And finally, we have to perform the response assessment by CT or MRI, and after 3 months later after the IRE. In the very early status in my institute, when we start to develop IRE treatment for pancreas, we consider percutaneous approach and the surgical approach, and there's some successful experience can be harvested in the literature review. And we finally adopt the experience of Professor Martin. For the potential of the complete operation, we perform surgical IRE for most patients with intention to treat, and the percutaneous IRE for small or recurrent tumor, and under CT guidance or ultrasound guidance. In the beginning, we created a huge wound to perform the pancreas IRE, always a combination with double bypass or hepatojejunal. And then we, through the learning curve path, we can decrease the wound size and to perform IRE only. And the method we used mainly was to perform the IRE by the insertion of antenna from caudal to cranial area and under the ultrasound guide above the stomach. This operation zone will cover the tumor adjacent or encased by the tumor, and during the operation, the patient should be sedated and paralyzed completely. And this is a very early case for us. The tumor is around 3 centimeters over the pancreas head. You can see when under the ultrasonic guidance, we perform IRE for this patient, and 40 days later, actually we cannot find the enhancement over this tumor. However, at that time, we cannot make a difference between the local edematous or the tumor operation. After 2 months, we can see the vessel is intact, and the tumor still without any enhancement. 1 year later, the tumor is still over there, but the size did not increase, and the vessel still keep patent. This is another young guy with a locally advanced tumor, a big one, 4 centimeters in size. You can see we perform the PET MR, and under ultrasound guidance, we insert 4 to 6 antenna into this tumor. And we perform the ultrasound guidance above the stomach wall and to insert the antenna through the mesocolon. This is the phenomenon during the IRE ablation. You can see some microbubble accumulated along the shaft of the electrode. And then after ablation, the tumor was ablated without enhancement, and you can see some microbubble within it. And after 9 months later, it became a cystic-like lesion without any enhancement. And this patient is an interesting one. We can see the vessel was encased totally and with the 360 degrees in this tumor. And then we perform IRE ablation and bypass this vessel and ablate the whole tumor. After ablation, this is a pre-IRE image. This is the phenomenon during the ablation. And you can see after the ablation, the tumor was ablated, and the vessel within the tumor was kept intact. And 1 year later, the vessel is still over there, and the tumor seems to be ablated. From 2012 till December of 2015, we collected 19 patients with stage 3, the locally advanced pancreatic cancer, diagnosed by enhanced CT and or MR. However, this patient was not diagnosed under diagnostic laparoscopic. So you can see, even they was diagnosed as stage 3, and 20% of them was confirmed to be a stage 4. 3 months after the treatment, and this patient developed liver metastasis, peritoneal seeding. It means our diagnostic efficacy is not so good. And the type of approach mostly was via surgical approach, and a laparotomic approach is contained 76%, and the laparoscopic patient is very quite limited. And the percutaneous echo guide or CD guide is totally take around 20%. And the tumor location mostly located in head and body area, and the tumor size mostly below the 3 centimeter in size. In this patient, diagnosed and confirmed with stage 3 locally advanced pancreatic cancer, it takes 72 patients. And this patient, most of them will receive additional therapy. And the type of the adjuvant therapy, including gemcitabine-based and the TS1 oral intake. TS1 oral pill is very common in Taiwan and Japan. It contains oral tegafur and gemcitabine and ultracil. And if patient can take the oral pill once or twice a day, every day, and the treatment could be started very quite earlier. And the recurrence rate, it takes around 1/3 in this patient. As for the local recurrence, it takes around 12%. And the other recurrence mostly occurred in liver metastasis and peritoneal seeding. From 2012 till 2015, and this patient was monitored under prospective IRE proven registry by Taiwan government. And the result showed during this median follow-up of 29 months, the complete ablation rate is around 87.5%. If we focus on the tumor smaller than 3 centimeters in size, the complete ablation is around 95%. And 11% sustained complication with the median grade of 2, actually is mild, was noted. And the median length of stay was 7.2 days. And 12.5% had a local recurrence, and 28.9% of patients experienced distant progression, mainly in liver. And the progression-free survival to the local recurrence was median 30.7 months, and overall survival was 22.5 months. The data is quite close to the result published by Professor Martin in neurosurgery. In patients with tumors smaller than 3 centimeters, the overall survival is better. We can obtain 28 months. And we come to some conclusion about, first of all, the diagnostic laparoscopy seems to be very important, because we have to make sure the patient belongs to the group of stage 3 disease. And if we just perform the contrast-enhanced CT scan or MRI, we will lose some minor metastatic patient in abdominal cavity. And the addition of IRE with traditional chemotherapy can provide a survival advantage no matter what kind of chemotherapy reagent. As for the complication, there is no mortality in my institute, and the complication rate is around 11%. The major complications, including the pseudo-aneurysm bleeding after pancreatic leakage or the IRE effect, pancreatic fistula to cutaneous area or into the intestine. Internal abdominal abscess occur in one cases. And then the minor complications include acute hepatitis, ascites accumulation, and mild GI bleeding, and the prolonged ileus. The current status in my hospital, now the case of the pancreas is increased in number, and the liver number is down. And during the follow-up, we will perform the CA19-9-LCE as a tumor marker 1 month later, and then keep a 3 months follow-up. And the MR and the CT scan will be performed 3 months after the IRE. PET scan, PET MR, PET CT will be performed half a year later. And contrast in ultrasound and the elastography, we try, but we cannot find the rule now. And from then on, since 2012, the first cases in Taiwan, till now there are at least 8 countries start to perform IRE for pancreatic cancer in Asia, including China, Japan, India, Thailand, Singapore, China, and Korea. And now we are trying to keep the workshop and the masterclass arrangement and the crosstalk and the consultation with the expert in Europe and the USA. And we try to perform a multi-center clinical trial and try to join the IRE Congress and the forum. And finally, the take-home message including IRE is a non-thermal or maybe a low thermal instrument. And the high voltage pulse will permanently open the pore intact cell membrane, no matter benign tissue or the malignant tumor. And that can eliminate the heat sink issue. It has already been proven by lots of documents. And they can ablate at or near vital structure, especially including pancreas cancer. And there is a potential to spare critical structure, including vascular and ductal remain intact. And then there will be a feasible and a safe modality for treating the locally advanced pancreatic cancer. Thanks for your listening.
Thank you, Professor Huaung.